Uh, Hi, everybody, dear friends, all of those who have logged in. I warmly welcome each one of you for the grand finale. I would call it the grand finale webinar of this IAB Basic Bronchoscopy Certification Course Program. So, as most of you have been a part of these webinars, this is the 12th webinar. I would say this is, in fact, the grandest of all for two reasons. One, for the topic which we will be discussing, that is the navigational bronchoscopy and the newer bronchoscopes. I think this is something which all interventionists should know. What is new and how can it help us? And also about navigation bronchoscopy, which is increasingly being adapted by several centers across the country. The second reason why this is grand is because of the grandness of the panelists who are there with us, the speaker and the panelists. I will be introducing each one of them as the webinar flows. And before we go on to the actual webinar, I should take time to appreciate and thank Amita Nede Madam and the entire team of IAB for conceptualizing this hybrid certification program on basic bronchoscopy. We have had earlier certification programs on EBUS and other areas which have been extremely well received. And this basic bronchoscopy also has been extremely well received. And each of the preceding webinars have been attended by more than 2000 delegates. That is a huge number. And today also I'm told that already 2300 people have logged in and more people are logging in. So that is a very, very big number. So I'd also like to thank Mankind and Olympus, Mankind Mr. Nitin, who has been with us in the previous webinars and this series also, and Olympus for the support which they have been providing. So with this brief introduction about the program, I would now want to, Nitin, can I have these slides also? Yes, thank you so much. Hope people can see these slides. So I will introduce speaker. So Dr. Nitesh Gupta, I'm sure none of us actually require any introduction. So he's a very my one of my good friends and also one of the strongest academicians from our country now. He is currently an associate professor at the Department of Pulmonary Critical Care and Sleep Medicine at Safdarjung Hospital, New Delhi. He has vast areas of interest. One of his key areas of interest is interventional pulmonology, bronchoscopy in all forms, and navigational bronchoscopy in particular. And I would also say that he has been avidly using the navigational bronchoscopy in his clinical practice. So with this brief introduction, I will request Dr. Nitesh to talk about the today's topic, that is navigational bronchoscopy and the newer bronchoscopes. I think this is something which all of us have to know. So over to Dr. Nitesh.
Right, sir. Uh, at the onset, I would like to thank IAB, Dr. Amita Nene ma'am, and Dr. Nagarjuna sir for the introduction and the opportunity to discuss the various aspects of the future of navigational bronchoscopy and newer bronchoscopes for our country. I'm extremely thankful to my panelists also for agreeing, and we hope to have a great discussion on the things as we go along. So, are my slides visible?
Yes, sir.
Yes, they have
Yes.
Okay.
seen.
So, navigational bronchoscopy and newer bronchoscopes, we have divided the talk in two parts. The initial part will be just discussing the navigation. How does it happen? What are the modalities globally available? What are the modalities currently available in India? And how are we going to use them? So, navigational bronchoscopy is a set of advanced imaging and guidance tool designed to generate a path. So, they just simply give us a pathway from our start point to our end point. We have navigational bronchoscopy in two forms. One is the manual, popularly known as bronchial branch technique, versus where we are dependent on the machines to generate and to use the algorithms to generate the pathways. So we'll be discussing a brief overview of both them. But the main questions come, why do we need the navigation? So navigational bronchoscopy plays an important role when you are using it for diagnosis of peripheral pulmonary lesions, that is in the outer one third of the lung, as well as when their size reduces, say less than 2 centimeter. That is where the role of navigational bronchoscopy has shown excellent diagnostic yields. The other sign is where you do not find a CT bronchus sign for the lesion. So that means there is no direct pathway which has been identified for the lesion. And this is where navigation helps you in finding alternate paths or the pathway which is very close to the lesion. Second is now we are moving into therapeutic portions, and this is now coming up big time, like fiducial marker placement for resection of solitary pulmonary nodules, and localized treatment for nodules is that is ablation, which has started occurring in our country, and soon in next 1 or 2 years we'll see a big jump in the number of cases being taken up for local ablation. So for the basic manual techniques, there is a this is known as proper bronchial branching technique, famously made by Dr. Kurimoto, and there are now various methods and which have evolved just to read the CT in the right direction and correlate with the CT and the bronchus anatomy, where you draw the diagrams, you go layer by layer, generation by generation, and you keep seeing what has been there on the CTs, actual in the bronchoscopy, and then you identify your targets and go for the lesion. So it has a learning curve, bronchial branch tracing. So the earlier you begin, the more expert you become, and you keep trying and learning it. Then comes how the machine works. So manually we have seen how our brain has to dissect the pathways first in the CT and then in the actual live anatomy during a bronchoscopy. So how machine works is you have a DICOM CT files of varied thickness as per the manufacturer instructions. You upload it in the system where software gives you a 3D figure detailing the airways as well as surrounding vasculature. Once we have the detailed picture, then it gives us a nodule or a lesion which we want to biopsy or we want to study. We have to mark it in all the three pathways, that is a coronal, sagittal, as well as axial cuts, so that it becomes a 3D round structure. And that pathway is created by the software. Depending on the software which we are using, it may give us three pathways, it may give us two pathways, it may give us the single pathway. And which pathway is closest or which pathway is chosen by the machine depends on the different manufacturers. Then comes, okay, once we know the pathway, now do I need to memorize the pathway and then go inside the bronchoscopy? Or can that pathway be just copied and reflect it live? That is, it guides me live during my bronchoscopy. So that is something which is available with one of the systems, not currently available in other system. So whether live navigation is yes or no, once you have live navigation, you reach your destination. So once you reach the destination which has been marked by the system, that is the time where you confirm the lesion by using a radial EBUS, whether I am actually there or not. Once the lesion is confirmed,
Uh,
Sir, you are on mute mode.
Dr. Nitesh, you have gone into mute mode. Can you unmute once? Arre. Dr. Nitesh, can you hear me?
am I audible now, sir?
Yes, yes. Dr. Nitesh, you're audible. We just lost the last 30 seconds.
Okay,
Uh,
sir.
that is the live navigation we have heard. And after that, reaching the site. So just 30 seconds, if you can repeat, it will be helpful for me. Yes.
So once the pathway has been created by the software, we try to overlap it and see whether during our bronchoscopy we can see that pathway live or not. Then once we reach that site, we have to confirm we have reached the lesion using the radial EBUS technique. Once the radial EBUS confirms the lesion is concentric, eccentric, or side on, then we use various tools, which can be in the form of brushes, which can be form of biopsy forceps, which can be in form of cryo of 1.1 probe, depending on the site as the size of the bronchoscope which has been able to navigate to that lesion. And once the lesion, the tool for biopsy is there, we need to ensure that tool is inside the lesion or at least on the side of the lesion and not away from the lesion. Because after confirming with radial EBUS, we remove the entire system and go with the tool. Now, to confirm this tool in lesion confirmation, we have other techniques where we are able to see it live. Yes, my tool is inside the lesion. Then we take the biopsies and send it for analysis. We can do an immediate rose in the inside the bronch suit and send it for further histopathology. So this is how a machine navigation works. So available techniques, first is virtual bronchoscopic navigation. So virtual bronchoscopic navigation is you create a virtual pathways using your CT scan, which has been done previously, upload into the software, and then it generates the pathways based on the 3D reconstruction of the software. So we have two techniques on the virtual bronchoscopic navigation. One is the lung point, which is by the Bronchos Medicals, and on the right side of the you can see is a Synapse 3D by the Fujifilm. We'll be discussing about each of these in detail in the panel discussion. But to begin with, lung point gives you an added advantage that it can create a live imaging section also where it during your bronchoscopy. Synapse 3D system currently do not have this facility and they are in the process of upgradation. Rest of the factors we'll discuss. In both the systems, you need to have a good quality CT. Both have their own specifications. At least of these cuts should be there from top to bottom, and they are uploaded. And since the software analyzes, they are definitely faster as compared to manual bronchial branching when we are beginning with. Now, then the other technique is cone beam CT navigation. We all have heard about this for last 2.5 years. We have multiple installations across the country throughout it. What the CBCT does is it gives you one thing, real time, three-dimensional visualization of peripheral pulmonary lesion. It gives you a true 3D imaging. That is, the image which you are seeing is exactly true and has not been redrawn by any software. It is as it is inside the lungs. It gives you an additional augmented fluoroscopy where the live pathway can be detected and you can actually track whether you are following the path or not. And then this is the only tool which gives you a tool in lesion confirmation, an actual true 3D image. Next technique is CAM based digital tomosynthesis. We call this as CABT. It is again a fluoroscopic image modality where multiple projections are done through the fluoroscopy machine and not through the CT machine. So CBCT uses a cone beam computed tomography. CAM based digital tomosynthesis uses your fluoroscopy. So it creates practically a pseudo 3D representation of the target region because this is not an actual computed tomography. It has been redrawn by the artificial intelligence software that this is how the lesion should look like and this is how you are approaching the lesion. So you can have an AI generate real-time 3D imaging and augmented fluoroscopy guidance. So augmented fluoro again helps you track the path in real time, but the image is again not true 3D, it's a pseudo 3D because it has been redrawn using the algorithms. Then the latest technique which is there available is bronchoscopic transparenchymal nodule access. It is the system by Bronchos Medicals by the name of Archimedes system. It integrates their virtual bronchoscopic navigation platform with the tunneling platform where you have a live 3D imaging because of the ability of electromagnetic navigation. So you have electromagnetic navigating platform, you have a navigating catheter which tracks that electromagnetic waves and gives you a live demonstration of whether you are reaching the lesion. Once it identifies, then it has software to tell you which is the least vascular tunneling point to get across the bronchus for the lesions which are not found. So it has an option of giving the optimal point of entry and avascular transparenchymal paths to reach the lesions which are not detected in the airway. Then comes the system, electromagnetic navigation systems. So these were the original navigation systems, have been around for almost 20 years by Medtronic, and then the recent one was by the Viren Medicals. So what they do is, once the patient is on the platform, they have electromagnetic platform also. So they do a computed tomography either at the site, or they do it, the one which has been done in previous 30 days. You load it in the software, it creates a 3D imaging of the airways, and then when once you are doing the procedure, while you are inserting the bronchoscope, there's an electromagnetic navigation catheter which in tips which detects the electromagnetic field which is there, and then it works live like your GPS system or the Google system, where you are when you are traveling in the car. Currently, this system is not available in India, probably because of its higher cost, and the yield has not been to that extent where it has been seen with the other systems. But this gives you a very good live navigation system during bronchoscopy and during peripheral pulmonary nodule sampling. So other systems which have come up in last say 3 or 4 years are the robotic bronchoscopy systems. We have three systems from the US and one from recently from Hong Kong, which is now making waves. So there's an Ion platform, there's a Monarch platform, there's a Galaxy platform. We can actually have few good series of webinars in order to have them in detail. But since they are currently not available in India, I'll not be discussing anything more. These are just the three ways in which they have a lot of technologies involved, they have a lot of softwares involved, where you can do the bronchoscopy. The advantage of robotic bronchoscope versus manual bronchoscope, which we do, is their tip. The tip and the catheters or the working practically the biopsies lesions which biopsy instruments which can come out through it. The tip becomes stiff when it reaches the target. It automatically becomes stiff. So there are less chances of divergence from the target, or we say the CT to body divergence ratio, which we will be discussing in the panel. So practically, theoretical, what we knowledge is not practical. So when we have a navigational success, that is, I have reached the lesion, does not mean my diagnostic yield will match the my navigational success, because diagnostic yield depends on a lot of other factors apart from just reaching the lesion. So this, if you have to take a one pick up for slide from this, so this is this slide where we clearly say navigation success is different and diagnostic yield is different. So when we talk about evidence for peripheral pulmonary lesions, is navigational bronchoscopy a good tool? Say a lesion is in periphery, accessible by both by CT. Why do I need to do a bronchoscope and then try to reach that lesion, which will take time? CT is very quicker. I can just get it done within say 10 minutes, 15 minutes. So to give an answer anything, you need to do a randomized control trial. So this was the trial which was published last year, the Veritas trial, where they have shown diagnostic accuracy of navigational bronchoscopy is higher as compared to transthoracic needle biopsy. It is not only the diagnostic accuracy, it is the complication of any grade, which is almost one-tenth, which is seen with the CT. As we can see, it is about 3.3% and 28%. And if you require admission for a pneumothorax, it is still less than 1%. So any procedure where a chance of pneumothorax is less than 1% is generally considered very safe, and it should be done very well available. So this was one of our earliest experience of navigational bronchoscopy. When we searched the literature, we could not find many papers which were there on use of Synapse 3D for pulmonology. It has been there for other fields. So we took the lead and analyzed initial 2 months data of our 11 patients, and we submitted it there. This is one of the cases which we have shown. So once we mark the lesion on the system, the lesion is marked, it creates a path. Then we confirmed it by radial EBUS, and then we took the biopsies under fluoroscope. So this was one where we have shown that navigational success was about 90%, and but diagnostic yield was about 80%, because in few cases you will be able to reach the lesion, but the biopsy after even repeated sampling may not turn out to be positive. So should we adapt virtual bronchoscopic navigation system versus non-virtual navigation system? So to give us the combined evidence, and instead of reading everything individually, we have systematic review and meta-analysis, where they have clearly shown VBN. If you see this slide, the VBN here is superior in favors VBN for lesions which is less than 20 mm. For lesions more than 20 mm, we may not see anything favorable, but for less than 20 mm, it is definitely favorable and should be used. So when we see for various procedures how it is going, we again divide it into less than 20 mm and more than 20 mm. For less than 20 mm, the diagnostic yield for either electromagnetic navigation, a virtual bronchoscopy, a cone beam CT has been around 80%. And if it is more than 20%, the yield does not differ by much. So we can say when we are using a virtual bronchoscopic navigation platform, along with the confirmation of tool and lesion, our diagnostic yields are going higher and higher with every passing, not years, it is by every passing month. We now see almost every month there is a paper coming on any of the navigational platforms and tool and lesion confirmation, where we have gone from the yield from 40% to 60 to 80 and now reaching up to 90 if we add robotic navigation system to it. So when we go to robotic systems, the yield has certainly be coming out to be higher, 80 to 85%. Some studies may show more yield, some may show lower because of the heterogeneity in the patient population, heterogeneity in the nodules, and heterogeneity even in the platforms that we are going to use. For the second part of the talk, we are now moving into the newer bronchoscopes. We'll next 5 or 10 minutes we'll be talking about the bronchoscopes. So if I have to go more and more into the periphery, my scope has to may become thin and thin. The problem is, say, if I pick up a neonatal bronchoscope and go into the 8th or 9th generation of the lung, but I cannot use any of the instruments through it, then also it is of no use to me, because neonatal bronchoscope which we use in our OTs for your double lumen intubation, they do not have a working channel. So you cannot neither do a suction, you cannot neither do a sampling. So we need scopes which are thinner, but gives us a working channel to at least take the cryoprobe, at least take 1.2 mm forceps. At least it should something should reach that lesion for confirmation that my navigational yield success is better and I am able to biopsy that lesions. So definition of ultra thin bronchoscope varies with the literature. Some investigators say less than 3 mm is ultra thin, while other consider 3.5 mm is the ultra thin. So for broad base, ultra thin is anything which is less than 3 mm or less. There are two bronchoscopes which are now available in this range. One has a working channel of 1.2 mm, other has a working channel of 1.7 mm. So 1.7 mm bronchoscope helps because it is able to accommodate a radial EBUS also along with it. So with radial EBUS, you get that confirmation of the lesion, and then you can use your biopsy tools, which can be larger. Thinner bronchoscope is something between 3.1 to 4.7. Then you have standard bronchoscope, and then you have therapeutic bronchoscope. But for peripheral pulmonary lesion, we have to go towards a thinner bronchoscope. So does ultra thin bronchoscope helps? So diagnostic yield has been shown to be favoring ultra thin bronchoscope, depending on what are the instruments we are using, whether we are using any guide sheet, whether we are using fluoro, whether we are using navigation. But on the right side of the screen is an important thing. It is practically the time taken for the procedure. So if you see, when you use ultra thin bronchoscope, it reduces your time by a factor of at least 5%. So your time gets reduced a lot when you are using a peripheral pulmonary lesion for an ultra thin bronchoscope for a peripheral pulmonary lesion. Now comes, say, I am able to do the bronchoscopy, I am able to reach, but I am not able to see my lesion. Even with my thinner scope, I am not just able to see the lesion. If I see, I'll be more confident, yes, I am sampling something right, and I'll be able to take more samples. So now there is a real-time direct vision by an iris scope. Practically, it is a bronchoscope which is of 1.3 mm probe. So something which is very similar to your cryoprobe of 1.1 mm, just a bit thicker to it. But the technology has been developed that you can load it into your standard bronchoscope and go more distally where your bronchoscope cannot reach. So your iriscope will be able to reach that region. You can see any mucosal abnormality. You can see any small growths there. You can see small nodules there. In our case, small cavities, which are there, especially in fungal pneumonias and in cavitatory pneumonias. You can just see and do a live biopsy. So this is something which will come up, and we are hoping to have this instrument in our country also soon. Then is, do I give away with my histopathology? Because the whole thing is, I have done histopathology, I have done the biopsy, I have come out, and my histopathology rows is also saying it is there, but sometimes the histopathology is at the end of the procedure or after doing the subsections from the slide set or from the histopathology says we have not been able to reach or we are not able to give you a diagnosis. So can the pre-test probability of abnormal region be predicted before, and then the biopsies can be taken from there? So conofocal laser endomicroscopy, it is basically a mini probe where you can go to the distal part of the lung. You can evaluate whether this is an alveoli, a normal alveoli, a diseased alveoli, a normal airway, or diseased airway. So this is still the work in progress, and we are yet to see a landmark study where this favors over the conventional techniques. Then comes, there are a lot of features given, just like you have a phone. You can just use it for connecting calls, ending calls, and maybe for few texting. But your phone has a lot of features which are not of use in majority of the patient, but in certain areas you need those features which are able to solve your issues. So will be here discussing about normal bronchoscopy is white light. So the other buttons which are there on the keyboard of your system, how do they work? So on your left you can see a white light image, and then you can see this is a narrowband imaging which tells us about the superficial mucosal vessels. Gastroenterology uses this a lot for their biopsies. Pulmonologist, we have started doing it, but we do it only for certain cases because we have still not been able to find the landmark image which tells us, okay, this is this to be biopsied and this not to be biopsies. For us it is more of avoiding the vascular region, as you can see in the image on the right, where you have link color imaging and blue light imaging. This blue light imaging and link color imaging is available in the Fuji system. The narrowband imaging is in the previous Olympus bronchoscope system. And then there are few other features which are there with the newer bronchoscope systems of Olympus, which is texture and color enhancement imaging, red dichromatic imaging, and eye scan, digital enhancement technology. All of them favors tells you about digital texture, brightness, and color enhancement. So practically they tells about certain mucosal irregularities and the bleeding vessels. So this is their target to identify. Then next thing in bronchoscope is single-use flexible bronchoscopes. How do they help? They ease of mobility, lighter weight to carry, transport is easy. They are more practical, especially in in ICUs settings where you need to reduce risk of cross infection. Simple, a transplant patient, we cannot take any risk of any, even the little bit of cross infection. It has to be a pure, fresh, new bronchoscope done and dusted. Where other bronchoscopes are helping us is in training of residents, training of staff, where maneuverability, cleaning techniques, and all can be taught on the scope without having the risk of damage it. And if you are going to do study, say microablation therapy in animal models, so this is where the use of these bronchoscopes have come up. We'll have a good discussion on this. What are the ones available in our country? How do we see them going up? Then comes the technology of Wi-Fi or a Bluetooth, where I want to go wireless. I have a system and I want a bronchoscope. I don't want them to be hanging around with the scope. So we have one of the systems in our country now where it's a Bluetooth enabled and Wi-Fi enabled, where the screen is separate and the scope is separate. There's no wire between them. It also has certain advantages and disadvantages. We'll have it in the panel discussion. So if you have not been able to understand what navigational bronchoscopy is, I would recommend it for anybody who wants to understand the very basics and have something of a say in navigational bronchoscopy. This is the article to go with, written by Nagarjuna sir and Pratip, published in Annals of Interventional Pulmonology, which is an IAB journal on interventional pulmonology. And I would suggest everyone to just have it a read. Even if you start from zero, you will have at least 80% knowledge. Okay, what is navigation bronchoscopy, what is can be done in India, and how these things work. I'm thankful for your kind attention, and I request Nagarjuna sir to please take forward from here.
Yeah. Thank you so much, Dr. Nitesh, for such a fabulous presentation and for making a complex talk very easy to understand. I think each line of what you have said, I think people have to listen again, and it has been such beautifully said on navigational bronchoscopy. A very brief about the newer bronchoscopes. Definitely, we will be discussing about all of these in the next 1 hour of our panel discussion. So thank you so much, Dr. Nitesh. And before we go on to the panel, I think it's also feels very nice to note that we have 2,300 doctors already logged in, listening to our webinar. This also shows the interest in bronchoscopy in our country and also interest in learning about the newer bronchoscopes and the navigational bronchoscope. I think this is the way forward. I think definitely this is the way forward. So before we start the panel, I would also request all the people, all the delegates who have logged in to feel free to jot down or to type the questions, whatever is there in your mind. We will try to take up as many as feasible in the given hour. And we have an extremely uh, talented panel here who have been first to start all of these navigational procedures and newer bronchoscopes in our country. So before we start, I would like to introduce each one of the panel members. So we have five expert panelists with us. So first, I will introduce Dr. Vishwanath Gela, who has been my senior, my colleague, my friend, and everything from the time I had been in PGI. So our journey now is almost for more than 15 years. And again, I will reiterate that none of the members here actually need introduction. But Dr. Vishnath has done his MD medicine followed by DM from PGI Chandigarh. Currently, he heads the department of pulmonology in one of the busiest hospitals in Hyderabad, that is the AIG Gachipoli. So he's an avid interventionist, but his interests are beyond intervention. He's a wholesome pulmonologist. He has a lot of high impact journal publications, and he has had hands-on on most of these navigational technologies. And we would look forward to listen to Dr. Vishwanath. So after Dr. Vishwanath, I would like to introduce Dr. Sham. So Dr. Sham is my very good friend from Kolkata. So Dr. Sham has done his DNB respiratory diseases, and all of us know that he is instrumental in taking intervention pulmonology to a higher level in Kolkata and all the regions across Kolkata. He is the lead consultant in interventional clinical pulmonology at CMRI BM Birla Hospital, and he's also a faculty of DNB Respiratory Medicine, co-founder of Vayu. He has a lot of publications. Not only publications, he's keenly involved in doing a lot of academic programs across the country. And there are a lot of other aspects to Sham as well. He also has several non-medical interests. Sham, I think you should also help me out in this thing. Huh? in patenting, in patenting, in innovating, and a lot of other things. So, as we all know, Dr. Sham also does cone beam CT, he does virtual bronchoscopic navigation, and he's going to start several new technologies in Kolkata. That is about peripheral bronchoscopy, but he also does a lot of central airway work. Then I would like to introduce Dr. Anshu Madam. Anshu Madam is from Mumbai. So we have expert panelists from across the country. So Madam is an associate professor and a faculty of oncopulmonology at the Department of Pulmonary Medicine, Tata Memorial Hospital, Mumbai. TMH is a place which everybody of us wants to work because of the highest volume of cases. I think they would have the highest number of nodules, more than what any one of us would be seeing. And also, I'm very happy that Tata is one of the centers to have started navigational bronchoscopy, and they are one of the first government setups to also install body vision by lung vision, uh, lung vision by body vision. So we will look forward to listening to Madam on their experience with manual navigation, virtual navigation, and so on and so forth from the busiest oncology hospital of our country, that is the Tata Mumbai. I will finally introduce also my dear friend, Dr. Hari Prasad. Dr. Hari Prasad also is from PGI. Currently, he is settled in Apollo Hospitals, Bangalore. He is a consultant in pulmonary critical care intervention pulmonology. He is one of the dynamic IP experts, young bloods from Bangalore, who is a part of the larger Apollo Bangalore team, and he is also actively interested in various aspects of intervention pulmonology, one of which being peripheral pulmonology and navigational bronchoscopy. I think with this, we will move on to the panel. So, as we start, I would request all of you to please keep their audios on. And though we will be asking questions to some people, I think we should have anybody who wants to pitch in can pitch in, because all of us are using navigational bronchoscopies and it is good to have a very nice discussion. So, now coming to the topic per se. Today's topic is divided into two parts. One is the navigational bronchoscopy, second is the newer bronchoscopes. I think both of these are extremely important in our country. Hmm. So, some of the questions which I would be asking might be a repetition from Dr. Nitesh's talk, but I would still ask the question so that it would, a repetition means we would remember better, and some of us who have logged in later would also be able to listen to all of us. So the first couple of minutes we will discuss understanding the navigational bronchoscopy, the need for navigational bronchoscopy, the various platforms available in our country, and we'll try to compare and contrast the various navigational platforms. So my first question to Dr. Vishwanath is how do we define navigational bronchoscopy for a pulmonologist?
Thank you, Dr. Nagarjuna, for the kind words of introduction. Actually, Dr. Nitesh has taken us through a very good presentation, actually. So to simplify it, I would say that once we go into the bronchial tree, we have a complex branching system. So especially when you're dealing with a peripheral pulmonary lesion, so you go into the bronchial tree and then get confused. So in navigational bronchoscopy, basically you are using an pre-procedural CT scan to construct a path to the lesion so that you'll go there in the least possible time and then be able to take a biopsy from that. So ability to construct a path using either different manual methods, which is called as a bronchial branch tracing, or using virtual bronchoscopic navigation softwares, electromagnetic navigation, or something like cone beam CT, which has been discussed. These are some of the things which can be used to create a path, actually.
So basically, navigation is to understand the path before we actually go in. So navigating yourself to the nodule or the lesion, whatever it is.
Yeah.
Now over to Dr. Sham from Kolkata. Why is it that we need navigational bronchoscopy? Why is it that in the current era we're talking so much about navigation as compared to the before? Can you just enlighten us about why is it important for the current generation pulmonologists?
Thanks, Nagarjun. So I feel, you know, we all envy the radiologists when they get a very high yield, and our standard was to match their diagnostic yield. And though we had thin bronchoscopes, we realized that once we delve into the peripheral airways, we tend to get lost because once the cartilage is gone, every small airway tends to collapse and we are lost. We are there, and suddenly we realize we are nowhere. And that is where I guess navigation helps, where it helps us uh, you know stay onto the right path of the right in the right bronchial or the airway path, and it helps us improve our diagnostic yield. And navigation in combination with, or in as a part, along with accessories like cone beam CT to look at the tool in lesion. And in the same sitting, you can also do a staging EBUS if you have EBUS. And you've shown a case or published a case where you've placed a fiducial marker which helps the surgeon. So all this helps to accurately, identify the path, identify the lesion, and help us take the sample from the right area and with minimal complications. So one reason why transthoracic, biopsies are less popular, or why we tend to show them as inferior, is because of the complications associated with them. So the rate of pneumothorax across studies is anywhere between 15 to 20%, which is like 1 in 5 patients. So I feel, so safety, the need for lesser number of procedures where you do staging in the same place, and better accuracy, I would say, in terms of reaching to the lesion and doing. And in future, if you have ablation techniques, you can combine that as well. That
Yeah,
is why
thank
I
you.
feel navigation is very important. And the earlier you get on board, you be the early adopters, you tend to get better at that. And when newer technologies come, you would improvise on those.
Yeah, excellent. So I would just add one point to what Dr. Sharma said. The second is that the number of nodules we are seeing also has increased. I think because of the increased number of CT scans, I'm very sure all of us will agree that before COVID and after COVID, the number of CT scans have increased. So the number of nodules also we are picking up. Incidental nodules have increased, and so is the need for us to do more accurate biopsies. I'd like to repeat one of these slides which has been shown by Dr. Nitesh, is the Veritas trial. I think this is a trial which all of us have to read, and it's a game changer, and it has given scientific evidence to what we have all been telling from a long time, that navigational bronchoscopy is now in the current era as efficacious as CT carotid biopsy. The diagnostic yield is similar at a much better safety profile. That is what Dr. Sham also has said. The pneumothorax rates are very less than 1% as compared to a CT carotid biopsy. So I think when and where it is feasible, it may not be feasible to everybody, but when and where it is feasible, I think we should slowly adapt to bronchoscopic techniques for sampling. And when we choose a bronchoscopic technique, I think adding navigation would help us in two things: decreasing the time taken to reach the lesion and improving the diagnostic yield. That also Dr. Nitesh has beautifully shown in his meta-analysis. So that is the need for navigational bronchoscopy in our country. Now, for the benefit of audience, I think this is there are a lot of terms which are there. So people have to understand these terms. It will take some time for people to understand if you're not seen these technologies. So I'll ask Dr. Anshu Madam, see what are, just name them. We don't want the in-depth discussion. We will go on about it. What are the broadly various navigational platforms available, and what are those which are available in India?
Yeah, so I think right now we actually have a large armamentarium to choose from in terms of the different platforms available. We mainly define them in the way the navigation pathway is created and whether we can do a live tool in lesion confirmation or not. So we have these virtual navigation platforms which are available in India, which is LungPoint and Synapse 3D. Then we have the further technologies like cone beam CT as well as CM-based digital tomosynthesis, which basically helps us to ensure a tool in lesion confirmation while we are doing the procedure, making sure that our sampling is in the accurate area. So for cone beam CT, I think we have Philips and Siemens, which are the two companies which are now providing this technology in India. And for CM-based fluoroscopic augmentation, we have Body Vision, which is what we have recently installed at Tata as well. If we look at Archimedes, which is a higher version of LungPoint from the same company, it combines the navigation pathway along with an additional feature where you can actually access nodules which are away from the distal bronchi as well, because sometimes it is not that you will always have a positive bronchus sign. So it can help you create a pathway or a tunneling like is done in CT guided biopsies to reach the nodule. Coming to more advanced versions, we have the robotic bronchoscopy platforms, which are currently not available in India. And Monarch and Ion were the first generation robotic bronchoscopy models. We now have the Galaxy systems, which also has the addition of tool and lesion confirmation, which was not possible with Monarch and Ion previously. And I think Nitesh Gupta sir has shown in a slide about this new model which has come from Hong Kong, which I have not read much in detail about, but I think it is the latest technology and probably a little cheaper than the versions made in US and Australia. We also have the electronic magnetic navigation, but these are not available, and I don't think they have any more advantage over the virtual bronchoscopy systems or the systems currently available in India. So this is how I would say that they are available.
Excellent, madam. So, Dr. Anshu, madam was just summarized. So, for everyone, I think in India, so India is moving very fast in the last couple of years. So, a lot of technologies which we never had, now we're having. So, we have broadly four groups of technologies. One is the VBN platforms, which we will be discussing. Second is the CABT, CM-based tomosynthesis, which Dr. Anshu madam has acquired recently. That is the lung vision or the body vision. And the third is the extra bronchial path, which in India we only have with one technology called Archimedes. Last is the cone beam CT. Cone beam CT, I would say, is not in a true sense a navigation because it doesn't give the path. We have to mark the path. So if you ask me, I may not call it as navigation, though CBCT navigation is the term which is used. So four things are there. All of them are there in our country. It is just that the centers which can adapt these technologies can use them. We don't have EMN in India. We don't have robotics in India. So we won't talk about those things at all. Now going on to each of these things, not in depth, but I think the common things which are increasingly being used are the so-called virtual bronchoscopic navigation, VBN. So now I'll ask Dr. Hari, can you just briefly talk about what is virtual bronchoscopic navigation and what are the two models which are there in our country?
Yeah, so virtual bronchoscopic navigation is a technology or rather an image technology, image guided technology, which uses the information that you get from the CT scans, in a high resolution CT scan. And this information is then spread into this system or the software, and it traces a path for you, a virtual path for you to go to the lesion. So the people, the pulmonologists who use radial EBUS, they know that how difficult it is to hunt for a lesion there. You spend hours, finding out where this lesion is. So this basically takes away that stress or, reduces the time to find that lesion. So you take the data from the CD, load onto this VBN system, the software makes a pathway to the lesion. Now, what you do subsequently is that you follow this pathway. Some systems may give you an real-time location where you are in the bronchus. In other systems, you're just following the path, and finally you reach where the nodule is or where the target or the lesion of interest is. But once you reach there, then now you can use your radial EBUS or other modalities, cryo, whatever it is. You confirm the position with the radial EBUS, and then you can subsequently take the biopsy there. The two VBN systems that we have in India is one is the lung point and the other one is synapse. So I think it has been elaborated in the talk as well. But the important thing is localizing the lesion. You get it from the CD information, then you have a virtual path, go to the site and then use the radial EBUS to finally find the lesion out there, finally confirm the lesion.
Excellent.
So that's what is VBN is.
Yeah. So Dr. Hari has made it simple. So basically VBN is a technology which will give us a virtual path. So there it will only give one step in the whole process of sampling. That is what we have to understand. So having VBN is not that you do everything. So it will only give a path to go to the nodule, nothing beyond that. So, but still that is very important. So that's what I will ask Dr. Nitesh. Now, Dr. Nitesh Center I'm sure, is doing both manual navigation and they also have access to the virtual navigation. Now, I think it is very interesting to listen from Dr. Nitesh as to what he would prefer and why. Manual versus virtual in your center, because your center is good in manual mapping. Your center also has Synapse. So now, when and how would you use Synapse at your center?
So, sir, so CT features gives us a lot of things. So, if we have a straight bronchus sign going inside the CT, manual is likely to be more successful and give us a good result. So, it is where the CT bronchus sign is not there. We prefer to go through the navigation platforms, and we have the Synapse platform at our center. We use it. The other thing is we now try to see whether the navigational success is there with both the paths, with both the methods or not. So we are right now studying on it. So navigation part is done by somebody else, the manual navigation, and the virtual navigation path is done by somebody else, and both are blinded to what is the path. So it is studied by the third person. So that is what we are trying to see how it is going. We don't know whether navigational success is same. Is it better in any of this? We may know it by the end of the maybe year or so.
Very nice. Thank you so much. Again, quick comments from Dr. Anshu Madam, who also has the VBN system, and Dr. Sham. Both of you are using the VBN platforms. So, do you do it in all cases, or how do you decide when you want to use a VBN when you're already good at manual mapping?
So I feel so Nagarjuna, the I feel the message which should go is uh, technology is always to equalize the skill set. There'll be an expert person and there would be a not so expert person. But then you can't, if you have to get the non-expert to the level of the expert, that's where technology helps. So if there's
Amazing.
somebody who spent time, say yourself or Shezang, who's very good at manual mapping, he might do it very fast or very quickly. So to able to be achieved to that level of expertise, uh, you use technology. So, but I feel technology saves time, and in a busy schedule when we are always multitasking, I feel using virtual navigation systems at present is basically to save our time.
Amazing. Dr. Anshu Madam, how is it you utilize Synapse or Lung Point in your practice?
Yeah, so we make it a point whenever we are planning any peripheral nodule sampling that we do go through the Synapse system and make sure that we have planned it through. But since we also have a lot of fellows in training, we would also encourage them to, do the manual mapping, because it's not always possible that when the setup that they would go after, they have finished their training. So they would have it. And sometimes it's fun to see and compare it with the virtual navigation pathway as well, to see, as which is more accurate while we are doing it. And it does happen that sometimes they are more correct than the software as well when we are doing the procedures. So
Amazing. I think three absolutely brilliant comments. The best part was what Dr. Sham has said, that not everybody has the same skill set as the experts in manual mapping. That is the catch, but you can become an expert. But otherwise, VBN is something which would bring the skills of everybody to the same level. At Art Center, any CT which is compatible for VBN, when we're doing, we do VBN because it saves us a lot and lot of time in manual mapping. We do manual mapping also, as Dr. Anshu Madam has rightly said, that not everybody has access to these things. So I think the message is that everybody should learn manual mapping, but in centers who do high volumes, I think VBN would definitely add value and save a lot of time. And people, not everybody is equally good in doing this manual mapping.
Can I add a
Now,
point, Dr. Nagarjuna?
Dr. Vishwanath, please, very quickly.
In addition to what they have said, actually, especially on the manual navigation front, actually, it can also be used in patients who have infective etiologies like tuberculosis, fungal, you have some consolidation or something. When they go out into the periphery, start practicing it, actually, they're able to actually go, they have a thin scope and are able to go into the exact subsegment or so. The yield of bronchoscopy or the biopsy will be better than just taking a regular bronchoscopy.
Amazing. I think I'm so happy that this has been told. In fact, there has been a study, I'm not sure that it has been published or not. Even BAL, a simple procedure as BAL, if you do navigation guided, your yield is better. Any lung biopsy, TBLB, whatever it is, if you localize to the sub segment and then do the procedure, your yield is going to be better. So I'm very happy that, see, navigation is not necessarily only for a nodule. Any peripheral pulmonary lesion, be it a cavity, be it a small patch of consolidation, whatever you want to do, you want to do a BAL, you want to do a TBLB, you want to do a cryo, I think if you add navigation to it, your accuracy is definitely going to go up. In fact, now, as Dr. Vishnu has rightly said, even if you want to do a BAL, we would still ask our residents to calculate the path, navigate as close to the target as you can, and then do the sampling. The crux is reaching as close to the target as you can. So, how do you do it? By the correct path and by using a thinner scope. I think these are the two things which is there. I'm very happy that Dr. Vishwanathan has brought this beautiful point. Now, the another, because see, the most commonly used navigational platforms in India are LungPoint by Broncos and Synapse by Fuji. So we will discuss more about these two, and we will little bit discuss about the Lung Vision and the Archimedes. That is the last couple of things. So now I'll go back to anybody in our group here. So who have had the hands-on experience of doing both LungPoint and Synapse. So compare and contrast these two platforms of VBN. So Dr. Vishnath can start, others can pitch in.
So I'm actually in our hospital we use manual mapping. However, I've had the experience of like seeing a lot of cases on both virtual bronchoscopic navigation by Broncos and also Synapse. One important thing which I have noticed is in the system with the Broncos, it gives us a real-time guidance. So the monitor can actually sync with the bronchoscopic monitor, and it tells us whether we are going into the right bronchus, right segment, right subsegment or not. So it gives us a green path, saying that you are in the right path. So you are supposed to go into this right path, and then take a biopsy from that. If you're going into wrong path, again similarly it will tell us that we are not going into the right path. So it gives us a real time guidance. In the system by the Synapse, actually, you have a path which is created before the procedure. You have to memorize it or draw it on a paper or something, or you have somebody standing by you showing the video of the navigation pathway, so that segment by segment and subsegment by subsegment you can navigate into the path. It doesn't actually sync with the bronchoscopic video, and it doesn't give us a real-time guidance actually during the procedure. That's
Any
what.
other comments from other people, other expert panelists who have used LungPoint and Synapse? Or
So
else I
I've used so lung so we have the Synapse system at our place just because of the cost factor. Lung Point is one which I feel is as of now technologically superior to the Synapse in terms of real-time guidance, and as well as its ability to integrate with the CT scan of the hospital. So I feel like you can have it's better value for money is what I feel. And the other thing is Lung Point for Synapse, you to get an optimal result you always need a contrast enhanced CT. And sometimes with a plain HRCT, if it's not done according to the proper protocol, it fails to identify the airway, which leads to the nodule. And you get a lot of times you end up in a situation where you're left stranded midway if it's just a plain CT. So I feel Synapse has a little bit of catching up to do in terms of and they promised that they would be upgrading the software and giving. So I hope they do that fast. But as of now, I
Nitesh has
feel
published his first article from Synapse with a 80% diagnostic yield. Anyway, I think
yeah, could have
very,
been
very
better
good
had he
things.
had luck point, I
Yeah.
guess.
So we have used both LungPoint. We've been one of the earliest users of LungPoint, and we also have used Synapse. I think one thing which I would want to say everything before we compare is the most important thing which determines the VBN success is the quality of CT we upload. Dr. Nitesh has said the point in the thing also. So if we upload a bad CT, none of these platforms will give a path. They will be lost. They'll be equally lost. So I think it is the quality of CT which is the most important, be it for manual navigation or VBN by lung point or VBN by synapse. The second thing Dr. Vishnu has already said is the live navigation facility, which is there for lung point, which is not there for synapse. But if you use any lung point user, nobody actually uses the live navigation because it needs another skilled person to operate along with the bronchoscopist. That's a challenge. So most of us end up memorizing the path and then going. So the more you do, the easier it is. So the live navigation, whether it is a value addition, is something which we don't know. Synapse is cheaper. That Dr. Sham has already said that it is cheaper than lung point. We would not go into the exact costs in this meeting. It's definitely cheaper, which is the reason why many people are opting for Synapse now. But lung point is more time tested as compared to Synapse. Unfortunately, to make a comment about which is better, we don't have a head-to-head trial. which we don't have a head-to-head trial, which is what Dr. Nitesh and me have been discussing over the last few months to see if we can get one out, lung point versus synapse. But for all of you who are there, who are listening to the webinar, VBN is there in two formats in our country. Both are good. Lung point is more time tested than synapse, but I think either one, if the CT scan is good, should probably help you. But we should never forget manual mapping. I think manual mapping is something which we should always remember. Now, very two quick points. Anyone, any comments on extra bronchial tunneling? So all of these paths, all of these things take us through the bronchus. It won't take us out of the bronchus. So I'm very sure most of us would have had cases where either there is no bronchus going or there is a bronchus going, but we are not able to go into that bronchus because of the airway size or airway angulation or whatever reason. So that is where the role of this tunneling comes in. So we will not dwell much into it, but any comments on the need of tunneling and the utility of these Archimedes or BTPNA? Again, Dr. Sham can pitch in, Dr.
Yeah.
Nitesh can talk, Dr. Hari
So
can
I
talk.
feel there is definitely a need, if not very commonly, but at least once a while, you would end up with a case where, the airway is not exactly leading to the nodule and it's adjacent to it. So how I bypass it, I don't have the Archimedes, the software, but what I do is I at least use the Periview, the flex needle which Olympus has. I try to tunnel it and then try to pass a 1.1 cryoprobe through it and take it. So
That is
that
the
is
essence
one.
technique which has been described.
So that is the.
I think there's some signal issue with Dr. Sham.
But having Archimedes always helps.
Yeah, wonderful. So Dr. Sham has beautifully said that not in all cases we would need extra bronchial tunneling. It's only in a small subset of cases where you're not able to reach. And this small subset is becoming smaller and smaller, mainly because of the advent of this ultra thin scopes and the advent of the cryoprobes. So more and more of the cases you are able to reach. And only in this small subset of cases we're not able to reach, you would want to tunnel. So Archimedes is a very costly platform. So we have access to Archimedes, but we don't use Archimedes very often. So we use it very selectively. What Dr. Sham has said is also very correct. That use of the Periview flex needle, the PTBNA needle, which is there by Olympus, it also has been shown to help us puncture, create a small hole, and then try to go out and then reach the nodule if you're very sure at which angle you have to puncture. But I would not want to go in too much detail about these tunneling platforms. There are some other tunneling platforms called as TBAT by the EMN, but we won't talk much about these tunneling platforms. I think I think we have had discussion about 30 minutes for navigational bronchoscopy. And a couple of some questions we will take. So many questions from the audience. I've taken some of them, but some very practical questions. This is by Dr. Zahir Sawant from Pune. How do you counsel patients regarding the diagnostic yield? Dr. Nitesh has said that our yield has gone from 40% to 70, 80, 90%. So with the availability of these technologies, I think each one very quickly, just tell the number. When you do a procedure, what is it that you will tell to your patient that my diagnostic yield is going to be how much? Then I will tell our number also. We'll start with Dr. Nitesh. What is the number you would tell?
So, depending on the size of the lesion, we usually tell them there's 80% chance because that is the best we have been able to achieve with our
Amazing.
setup right now.
Dr. Sham?
Yeah, I'd say 75 to 80. And I always tell in case we don't get, we would refer you to the radiologist. I add that line also.
That is very true. Even we do it. Dr. Anshu, madam?
Yes, the same thing. I would say around 70 to 80%. And yes, we have a very good radiologist also available if we can't actually get the diagnosis.
Dr. Hari?
We still do the manual mapping here, so we can't have it.
No, the question is what is the percentage you would tell to your patient, that what is the chance that you would hit the target and get a diagnostic yield?
So the same 70 to 80%, but we give them the caveat there. If we don't hit the lesion or we don't get it again, we get the radiologist also involved. Actually, we do one more thing there. When we do the biopsies, we also call the radiologist to the OT. They also have a better view of what is happening there. We have seen
So
that
hybrid
over
OT.
time.
So
Yeah,
hybrid
so they also get oriented to what we are actually searching there.
is Dr. Vishwanath, very quickly. What is the diagnostic yield you would tell?
We would say little less than 60 to 70 is what I say, tell my patients. If it's
So
positive,
Dr.
they're
Vishnu
happy.
is being very, very safe, very safe. So I think, see, what the message we have to say is we should never tell 100% diagnostic yield. We should be truthful. So at our center also, we would tell for a lesion more than 2 centimeters, we will be confidently 90%. Less than 2 centimeters, we would tell 80 to 90%. That is what we tell. And with the advent of cone beam CT, our diagnostic confidence is also significantly gone up. So I think that is an excellent question, that we have to realize that we still have limitations. Despite the best of technology, our diagnostic yield is 80 to 90%. 80-90% is what we have now. Then to one more question, I think, which I will ask Dr. Vishwanath. When do you prefer CT guided biopsy or navigational bronchoscopy? We have discussed the advantages of navigational bronchoscopy, but is there any instance where you want to prefer CT guided biopsy over navigational bronchoscopy?
So if you have a patient who has a subpleural lesion, actually, we can refer for CT guided. Or if a patient has a contraindication for bronchoscopy in general, so we can refer these kind of patients to CT guided biopsy, actually. These are the two main subset of patients which we refer for CT guided biopsy.
Okay. Any other comments, Dr.
We
Sham?
also check that if
Yes.
we don't have we don't have an intervening lung in between, that is one of the first things we look at.
Absolutely brilliant. So if it is touching the pleura, CT guided biopsy, I think most of us will agree that is the one definite indication for CT guided biopsy. A lot of other cases where you might want to do CT guided biopsy, CT guided biopsy is still cheaper than any of the navigational procedures. I think if a person cannot afford a navigational procedure, we should not deny them a CT guided biopsy. Third is again, I think I would add this after the next question. Can navigational bronchoscopy be safely done under conscious sedation by Dr. Mangesh, Mumbai? Dr. Anshu, madam.
Yeah, so when I was training in UK, we had the early version of lung point over there, and we used to actually do all our procedures under conscious sedation. I think it depends on the expertise of the person doing it and how far the lesion is away from it. However, if you are a beginner or you expect that the procedure will take a longer period of time, it's better to have the patient under general anesthesia, especially if we are going for lower lobe lesions where we know that atelectasis does set in. So we would want to make sure that we can use the proper ventilation protocol, so not to get a false localization with radial EBUS for atelectatic segments. But it can be done if you are expert enough, and you can do it as such. Over here we mostly prefer doing it in general anesthesia though.
Yeah, very well said, madam. So I think the smaller the lesion, more is the stability we need over the breathing pattern. So if whenever feasible, I think deep sedation or general anesthesia. That is what I would say. If a person is coughing and moving, I think it would not be correct to do a procedure. So the third benefit of CT gate biopsy over navigational platforms, I think, is the person who's unfit for deeper sedation or general anesthesia. If somebody is unfit, then probably you won't be able to do the procedure. So lots and lots of questions pouring in, but we will come back to the questions because we also have wanted to discuss the newer bronchoscopes in the market. I can understand the interest of the people because navigational bronchoscopy is the hot thing now. It's the hot thing now. You have, because of the number of peripheral lesions which are increasing. Slowly, lung cancer is moving from squamous to adeno. So we'll be seeing lesser of central airway lesions. We'll be seeing more of smaller nodules. So I think we should all be more adept with the peripheral bronchoscopic technologies. Now we'll move on to the newer bronchoscopes. I think, see, this is something which is very, very, very important for everyone to know. The plethora of scopes which are there. I think a decade ago, there's only one player in the market. Now we have so many players in the market. Earlier, we only had one or two sizes of bronchoscopes. Now we have so many sizes of bronchoscopes. and we have so many features in the bronchoscopes. So, but the thing is, we should know when they have to be used. A new scope does not mean better diagnostic yield. I think this Dr. Nitesh has so nicely said, compared the newer modes with the phone features, that they may be fancy, but they may not be actually beneficial in all cases. That is what we want to understand now. Now, again, moving to the scopes. So I think the most important change in the scopes is the diameter of the scopes. So we will talk about the thin and ultra thin scopes. So I will ask one question to one panelist, but I'm sure most of you can pitch in. So first we'll talk about thin ultra thin scopes. I'll ask Dr. Anshu Madam again, mention the models and the benefits of using these scopes. So in the practical things, what are the models, which companies have these scopes?
So Olympus, Fujifilm, and Pentax, they all do come with thin and ultra thin scopes. Mostly they would have P written in the code for the scope when it is meant as thin or ultra thin. With definition, we would say anything which is less than 4.5 millimeters. So between 3.7 to 4.2 millimeter is the definition for thin scopes, and ultra thin is anything less than 3.7 or less than 3, as Dr. Nitesh sir has shown in his talk. They have a working channel which ranges from 1.2 to 1.8 for ultra thin scopes, and then you have a working channel of 1.8 to 2 millimeters for the thin bronchoscopes. The advantage is that you are able to go into more peripheral subsegments using these scopes. So if you are able, you can go more beyond the third and the fourth generation subsegmental levels. And using the ultra thin ones, you can actually even reach up to the subpleural areas if you know how to navigate it properly. They also have better angulation than the therapeutic scopes that we have. So the upward and downward flexions are 210 degrees and 130 degrees. And now the thin and ultra thin scopes do also come with a rotatory function, especially in Fujifilm and Olympus scopes, which gives you the advantage that, you know, if you are not able to go into the segment, you could just rotate the scope and then it could navigate to a more difficult to reach segment, especially in the apices of the lungs. A lot of the single-use bronchoscopes actually also provide you with a lot of variety of thin and ultra-thin scopes. So the main advantage is that you are able to go more deeper and deeper into the lung and reach more peripheral lesions, I would say.
Amazing, madam. So the two main advantages of the thin ultra thin scopes are: one, you go more distal. Second, you are, one thing is very important, correctly said, their flexibility is more. So their anti-flexion, retroflexion ability is more than the conventional adult bronchoscopes. Very well said. That actually takes us easier to the apical subsegments and so on and so forth. And now what are there in the market? Olympus has been the initial player. So they had the thin and ultra thin scopes, 4.2 outer diameter and 3.7, you can correct me, outer diameter. Fuji has a thin scope, but I don't think it has an ultra thin scope.
They have a 4.2 with
Yes,
a
so
2
that is a
millimeter
thin scope.
working
Yes.
channel.
So
Yeah.
Fuji has a thin, but
Thin,
Fuji
yeah.
does not have an ultra thin scope. Pentax, I'm not aware whether it has a thin or
I think
ultra.
it has just one scope, which is, I think, less than 4.5 millimeter, if I'm not
So Pentax,
outer
but
diameter.
the other beautiful thing which Dr. Anshu Madam has said is that most of the single-use flexible bronchoscope players also have the thin scopes and the ultra thin scopes. So if we want to have a thin scope, ultra thin scopes, now so many options to choose from. Correct. So I think that is very nicely said. Now, Dr. Hari, thin versus ultra thin. So now we are very clear that for a peripheral nodule, we don't want the adult scope because it doesn't take you deeper. Now, if you have to choose between ultra thin versus thin scope, what would you choose and why?
Now, that's a difficult question to answer. The
That
ultra
is
thin
correct.
will lead
Carefully.
us. It would probably the ultra thin would probably lead us much further than what a thin scope can lead us to. But as people, we have used the ultra thin, we know how a little unwieldy it is, and the sample size automatically comes down. And if you're looking at ISCs and all those things, if you're not using the cryoprobe, then it becomes a problem with the ultra thin scopes there.
So, Dr.
So
Nitesh, your comments on ultra thin versus thin?
Yes, sir. The thinner it is, the better it is. The only disadvantage with ultra thin is they have higher chances of getting damaged very frequently.
I'm so
That
happy
is
you said this point.
something which has been, and you sometimes feel they are not following your order, they are running in their own way.
Yes, so I think ultra thin will take you as one generation beyond what a thin can take. It has more flexibility, but an ultra thin scope doesn't have the same visual clarity because it's a fiber scope as opposed to the thin scope. And in an untrained hand, the thinner the scope, more is the damage to the scope and to the finances, not to the patient. So I think the ultra thin, the thinner the scope, the more senior the person it is who should be handling it. Otherwise, you're bound to get dots and the scope will get damaged. The other disadvantage of ultra thin is the thinner the scope, smaller is the camera or the fiber or the thing. So the more fogging, the more often you lose the vision. So you need to be extremely skilled if you have to use an ultra thin stably. I think that is what it is. But I think the important thing is the more deeper you have to go, the smaller the scope it has to be. So we use a lot of ultra thin in our peripheral nodule sampling. Now talking about thin, ultra thin and miniature scopes, I will ask Dr. Nitesh because he has already spoken in his presentation about the next generation slimness, the iris scope. So how would you position it in our country? Do you foresee that it's a game changer? So very briefly about iris scope for Indians.
Right, sir. So iriscope we have seen, it's a miniature probe which goes inside your main bronchoscope, and where your bronchoscope ends, this will begin your second part of bronchoscopy. So, and the more the lesion we see, the more confident we are, and higher is the yield. That is what the dictum has been. So iriscope will definitely be a game changer once it comes here.
So it's actually a scope in a scope. That is what it is said. So the iris scope is a bronchoscope which goes through the working channel of another scope. And that it will take you even closer and you will see it comes with a sheath. It's by a Belgium company. I'm not
List medical.
correct, no? So, hoping that it will come very soon in the Indian market also. The thing is, if you can see the lesion, then your confidence that you are there is higher. So probably it may increase the rate, but we don't have very robust randomized evidence to say that actually iris scopes would improve the yield. But that's a newer scope which probably will change the way.
Like Arjuna, I have a doubt actually.
Yes, yes, Dr. Vishwanath, please.
Does it have a biopsy capability, the iriscope?
So the iriscope comes with a sheath. It comes with a sheath.
So,
So that once you see the lesion, you remove the scope, the sheath will be there, just like radiolibus. In radiolibus, you are seeing the ultrasound image. In iriscope, you would see the original image, the nodule per se. Once you see the nodule, then you would probably leave the scope there and the sheath will be there and then you go and sample. So that's about the iriscope, but we won't discuss much about it because we don't have it in our country. Maybe the next time IAB does a bronchoscope series after 2 years, we will talk more about the iriscopes and Dr. Nitesh would publish his initial experience in the Annals of Interventional Pulmonology, the official journal of IAB, on his initial experience with the iriscopes. So now, and I would, because the next question is extremely important. This is a new era, the era of single-use flexible bronchoscopes. India is slowly trying to adapt it, but the world has adapted it much earlier. That is the so-called single-use flexible bronchoscopes. Still 3 years ago, we were only using the reusable scopes, the Olympus, Fuji, Pentax. That's all. Now we have at least I can think of at least several companies which have come up with these single-use flexible bronchoscopes. So, now, Dr. Vishwanath, what are these single-use flexible bronchoscopes, and why is it that globally the trend is moving towards single-use flexible bronchoscopes from reusable bronchoscopes?
So typically, most bronchoscopes we reuse them, we disinfect them and reuse for next patient actually. But in certain situations where the risk of infection is high or immunosuppressed patients, these kind of patients actually, if you are using a scope which is not disinfected properly, there's a chance of cross infection from patient to patient actually. So typically the bronchoscope, single-use bronchoscopes from the different companies came for these indications actually, used in ICU settings, used in immunocompromised patients actually. And also now we are also seeing that in setups where there is no bronchoscopic tower, or in odd times when you have to do a bronchoscopy, actually people are increasingly using the single-use bronchoscopes because the system is very portable, can take it to any setup and then use it immediately. And even in maybe peripheral settings, also a lot of people have started in the district setup, especially they're using this single-use bronchoscope. But in India, what we see is the single-use bronchoscopes use is not commonly a single use, and probably typically people are using it for maybe 5 patients, 6 patients, or something like that actually.
So thank you for being so truthful. Dr. Vishwanath has been very, very truthful in whatever his words say. The predominant intent of single-use flexible bronchoscopes is to reduce cross-infection. So that we use the scope, we throw the scope. Hmm. So the main problem with universal adoption of single-use flexible bronchoscopes in India is the cost. I think if you have to throw the scope every time, it would obviously be more costly than a reusable scope, but they definitely have some place. I think, especially when we're talking about cases like transplant pulmonology, or when we're dealing with very resistant infections like MDR, TB. I think these are definite indications where probably we should use single-use flexible bronchoscopes. Now, Dr. Vishnu has beautifully said how we are adapting the use of single-use flexible bronchoscopes because they are portable. They come with small display monitors. I think many people are using it in the ICU setups. Many people are using it as a bedside bronchoscopy where the patient can't come to the bronchoscope tower. These scopes can go there. I think all the panelists are agreeing to what I am telling. That is how it is being used now. And very, very practically, where people cannot afford a full setup, people are taking the single-use bronchoscopes and then doing it. I think this is how we are using single-use flexible bronchoscope. I think slowly, as the cost comes down and as our affordability goes up, as more insurance companies accept these single-use flexible bronchoscopes, definitely I think the use of the utility will go up. I think Dr. Nitesh has beautifully said about training with single-use flexible bronchoscopes. Even if the trainee damages his scope, your pocket is not deeply hurt. Correct. That is another important thing. So a lot of uses of single-use flexible bronchoscopes. Now, Dr. Sham, can you just list whatever comes to your mind, the common companies, various companies in the market, and can you just amongst the, I know it's a very tough question, whether you can compare the various companies and you feel that one company may be better than the other, or one specific model you feel is giving you an advantage over the other models amongst the single-use flexible bronchoscopes.
So I've used three companies I've used. So one is the Ambuscope. They were the initial ones, and especially the whole the single-use fiber optic bronchoscopes, it basically gained popularity during the COVID era, where you had a lot of ICU. You didn't want to cause cross infections while doing a bronchoscopy. And doing a bronch that time itself was considered taboo, where you didn't want to aerosolize. So I think so all of them gained the popularity there and acceptance during that time, and the number of transplants also increased during that time. So from that time, I feel so Embu were the very first ones to enter the market. Then we have the Wathen scope from St. Luke's. They're the ones who manufacture them. And I've used the Palmo one by Pentax. So these three, and I've demoed VisiScope, but haven't used them for a long time. But so I feel Embu, the latest Embu has, though it's slightly a tad expensive compared to others, the image quality is very good. The image quality, and if you use it true sense as a single use scope, obviously Embu, the quality is much better, image quality is good, and now the working channel is also pretty big. Pentax initially had that advantage where with a therapeutic scope, you had a 3 working channel. So even for some cases where you had to do a stenting, right main bronchus, you could pass a bona stent of, a 10 stent through the working channel of the scope. And to clear out thick mucus clots, it used to help very well. So that one advantage the Pentax had. But now even the other scopes, the Wathin as well as Ambu newer scopes have the 3 working channel. And if you want to use the single use scope as multiple use scopes, multiple use thing, I feel Wathin is better in terms of cleaning and disinfection, where there are less, you can actually remove dismantle parts and sterilize it and use it for 5-6
Yeah.
procedures.
I think Dr. Sham has done a lot. I think it's best not to promote single-use bronchoscopes as multiple-use
Multiple,
bronchoscopes.
yeah,
Yeah, I know, because they're meant, designed to be
single
single-use.
use.
But what Dr. Sham has said is very correct. The current generation single-use flexible bronchoscopes have the same or better visual clarity. They're all HD now. You have HD clarity, visual clarity with all the newer generation scopes. Ambo has been the pioneer. Pentax has come up. Olympus is planning to come, and there are a lot of companies which are exclusively for single-use flexible bronchoscopes. The Vatin, the Visi scopes, some more are there. I'm not getting. Anyone can tell another some other names. Anshu madam can pitch in.
I think Bronflex is also a company. I think they had come sometime. Yeah.
Yes, so I think two or three more
But
companies are there in the Indian market, which you cannot immediately name. But see, I think Dr. Sham has brought out one point, that these single-use flexible bronchoscopes come with some unique technical advantages over the conventional adult bronchoscopes. One is the one he has rightly said, the larger working channel. So, Dr. Anshu madam, can you also comment on other technical advantages of these single-use bronchoscopes or the conventional adult scopes?
I think one of the main advantages that I think is the portability of these scopes. You also have, you can, it's in an emergency, it's very easy to set it up. Also, if you are doing major airway procedures, I think a lot of centers now do have an AMBU as a standby, because when you have done a cryobiopsy and while you're pulling out, somebody can actually go in and check that the bleeding is not there, and help with at least clear out the clots and everything using that. In terms of, I think, Ambu, the newer versions, the ergonomics are very similar to the reusable bronchoscopes. The initial challenge with the older Ambu scopes was the working channel was right at the top of the scope. It was a longer working channel. So if you, whereas now it is very similar to what the normal ergonomics of the suction working channel are there with the reusable scopes. I think some of them have also now come up with the rotatable functions, and there are some versions where you can actually it's available, I think, with Olympus in America, where they are single-use bronchoscopes have a locking mechanism. So if your scope is flexed and kept in that, you can just keep it over there with your bronchoscope holder, and then it doesn't move while you're doing your biopsies and everything as well. So
Amazing. I think very well said. That was one thing I was waiting for. We have a something called as a locking system for the what do you call that? The anti-flexion retroflexion
when
lever. But I'll add one or two more things. For the same diameter, I think the single-use flexible bronchoscopes have more flexion ability as compared to the conventional scopes. That is one thing which is there. If you can check also, they have larger diameters, which Dr. Sham has said, which brings me to the next talk question. I think Dr. Nitesh can pitch in. The conventional adult therapeutic scopes had a 2.8 working channel. But now we are seeing a new generation therapeutic scopes with 3 or more working channel. So can you just tell the scopes which have 3 or more working channel, and what are the indications where you would need a larger working? How will a larger working channel benefit over a 2.8 working channel?
Yes, sir. So larger working channel helps us in gives us an important suction
Yes.
area for cases where you're doing central airway procedure and they are bleeding. So that is where it helps. Plus, it helps you get instrumentation more, especially with the larger size CRE balloons. So above the 9 or 10 size CRE balloon does not go through the 2.8 channel, but it goes through the 3 working channel. So when we do the cases, we try to use a 3 more, because we it gives us a one go bronchoscope for a larger CRE balloon also.
Amazing. So while there is a demand for thinner scopes, ultra thin scopes, peripheral lesion, there is also a need for larger working channel in the conventional scopes. Now both Olympus and Fuji has come out with their newer models which have 3.2 mm for Fuji and 3 mm for Olympus. These are the two largest working channels in the Indian market. Olympus is another scope with 3.2 mm outside India. So these larger working channels will give us better suctionability, suction when the accessory is inside, ability to pass a larger balloon. As Dr. Nitesh has said, we also try to send 10, 11, 12 balloons through the working channel of the larger scopes. And now with the advent of through the scopes 10 deployers, I think with the larger channel, it will become much easier for us to deploy through the scope stand, as Dr. Sham has rightly said. So the other advantage, other difference in the scopes is the larger working channels which are available with some of the scopes which are there in the Indian market. Now we'll quickly finish off the discussion about scopes. We'll talk about the wireless scopes. I think this is a new generation of scopes which is available with one company, Dr. Anshu or Dr. Hari, the portable scopes and the wireless scopes. Anyone can tell. Have you used them? And how do you feel they can help you or they are not very helpful?
I think for the wireless video bronchoscopes, we have one company in India, which is the Scope. The advantage is that there is no cable connection needed between the scope and the monitor. So there is less wires in the OT or wherever you are doing the procedure. It basically gives you real-time imaging on the monitor without all these hassles which you are there. Other advantage, it's reusable. It's not a single-use scope. It's also more pocket friendly. So for beginners, I think, who are starting out their own practice, it is quite useful to have a cheaper version which is reusable. We are a very heterogeneous healthcare, country. If you have very good centers in tier 1, you also have your tier 3 and your towns, which are mainly catered to by nursing homes. And you would have pulmonologists who are actually going to different setups, trying to do their procedures. This would be very convenient for them to do it, because it's a portable system. The monitor is not very heavy to carry. So the bronchoscope and all can fit in, and you can set it up everywhere and do it easily. So we have just done a demo. We don't have it at Tata as of now. So not any much.
So has anyone used a Visiscope in their practice? Any of the panelists? We have tried it in one patient, but then we have not used it regularly. Dr. Nitesh, can you comment? You were talking about in a presentation also.
Yes, sir. So we had a longer demo come usefulness for the screening, and probably in next year one of the departments will have it also. So the major difference is in the weight of the bronchoscope, because the battery is attached at the top. So when you are holding it, you always feel like something is falling aside, because since the battery at the top, it tries to swing it to on either of the sides. So that is where the suction needs to be improved. It is not still up to the standards or the sounds which we are used to hear. So something which we are used to hear, when we are not hearing it, we feel something is not going right. And again, the connection with the screen, we are all used at it. We to see those black wires coming out, and we know, yes, the whole system is connected. And when we don't see them, it's a bit different. So as ma'am has said, maybe for somebody who is beginning a practice in a setting, he may start using it, but still I am not very comfortable with the weight of the scope. Actually, it is quite heavy. It is quite heavy.
So I think it's time. Time will tell us how each of these scopes will fit in. Probably in the ICU setup, the taking a scope itself is tough. If you have a wireless scope, it will be very, very helpful probably. And there's another new generation bronchoscopes called as dual channel bronchoscopes. I think some of us have heard it. It is not there in India. Your comments and thoughts, Dr. Hari.
Yeah, so I think that
We're
is
talking about one channel. Now we want two channels. The gastro people have an endoscope with two channels.
right. So, I think all of us would have used a Fogarty to stop a bleeding. And sometime at least we would have thought it would have been nice if you could give a, cold saline or an adrenaline through a different port there. So I think these are the situations, not, a suction at the same time as at the same time as you're using a Fogarty or a different instrument. So what I read from what's available is that these scopes have two channels so that you can pass an instrument through one, and at the same time you can continue suction or do some other thing with the other channel. But practically, it looks quite nice. If you have a bleeder going on and you have the luxury of two channels, it looks quite good theoretically, but I have no idea how it will span out in the practical front.
Yes, so I think there's only one Chinese
Mhm.
company which is marketing it in China, dual channel bronchoscopes. The only problem is the diameter may be a little larger. Dr. Vishwanath, you wanted to say something?
No, no. I didn't have the experience of using a dual channel bronchoscope. However, in few patients who were on ECMO and who were having mucosal bleed, when we tried to do an APC with a regular therapeutic bronchoscopy, every time when we were trying to do APC through the working channel bronchoscope, the bleed was coming and obscuring the vision of the bronchoscope actually. Then we requested our gastro colleagues to lend us their pediatric endoscope actually. The pediatric endoscope almost is like our therapeutic bronchoscope actually, almost 6 to 7 mm actually. We were able to pass it through the endotracheal tube. We were able to use the APC, and then at the same time, we were able to do suction of the same thing. So that is the primary use case actually. So, but because being an gastroscope longer in length, we'll not be able to. We are not used accustomed to holding this actually. So this definitely in cases of bleeds, especially in ICUs, actually it would be very helpful to use both the accessory and have suction at the same time actually.
Yes. So I think if it is there, probably all of us will use it. I think that much, I think we would say, just that we don't have it. So school of food for thought for the people who are making the bronchoscopes. Last two questions on the newer modes. We've discussed about the thinner scopes, scopes with larger channels, single use flexible bronchoscopes. We discussed about the wireless bronchoscopes. We discussed about dual channel bronchoscopes. So many scopes are there in the market. I think I might have missed some of them. But also we should talk about the newer modes in a bronchoscope. I think what all of us should realize is that whatever we do is called as a white light bronchoscopy, where we only give white light that is all wavelengths and then we see the image. That is what we are tuned to see. But each of the newer generation of scopes have a lot of other modes in them. So that's called as a non-white light bronchoscopy. So there are some modes which give only few wavelengths, so we see colors. There are some other modes which will enhance the surface features. That's called as surface enhancement modes. So three or four modes which are commonly available, I will ask each one panel to explain whether they're relevant or not. So Dr. Nitesh, NBI, narrow band imaging of Olympus, BLBLI of Fuji. I think they are similar on a conceptual basis. So, what are they, and do you think they are relevant to the pulmonology practice?
Right, sir. So they just tell us about the superficial mucosal pattern and the vascularity pattern on the lesion. So they help us in avoiding a very large vascular area initially on biopsy, both LCI as well as the NBI. But what we wanted to see is just like in gastro, where early mucosal abnormalities are there, and when they biopsy them, they actually turn out to be positive. So we have not seen yet that much of change in our practice where we are able to say even in sarcoid, if we put NBI and do a biopsy versus if we don't use NBI and biopsy, yield has been same. So it has not given us any advantage till date or a specific indication where you yes switch it on and your yield will be higher.
Yes, very true. So that is the take-home message. It's a mode which is there for most of the Olympus scopes now, but will it improve our diagnostic yield? Will it help us in picking up early precursor lesions like what is happening in endoscopy? It has not been shown in pulmonology. There are 2 to 3 randomized controlled trials of NBI in sarcoid, one from PGI Chandigarh, but none of them have shown that addition of NBI would lead to a greater pickup of granuloma or an earlier pickup of malignancy in pulmonology. So I think that's a mode which we often use sometimes to look for vascular patterns, that's all, but it has never been shown to improve the diagnostic accuracy or yield. Dr. Vishwanath, so now Olympus, the new X1 series, has come up with a mind-boggling number of newer options. I think for a beginner it becomes very confusing sometimes. So now we have something called as RDI, something called as TXI, and the Pentax comes up with something called as iScan technology. So all of these modes, can you just briefly tell about their benefits and do you truly feel that they would make a difference?
So as like newer models of mobiles, newer scopes are also coming with newer imaging modalities. So whether two things is what are the modes and whether they will be useful in real life or not is the two things to be discussed. If you look at the newer X1 bronchoscope, we had a demo of the X1 bronchoscope where we had a chance to try these modalities actually. TXA is the surface enhancement mode where you're able to see the mucosa very clearly, the color is bright, and then the lesion appears, maybe early mucosal lesions can be picked up very clearly. So basically, there is enhancement of the surfacial mucosa actually. So that is about TXA. And the other important mode which they have introduced is the RDI. So they change the wavelength of the light and then try to see what is there within the deeper lesion. Suppose you have an endobronchial lesion. So there might be an endobronchial lesion without a deep vessel inside. There might be a lesion which a deep vessel inside, but you will not be able to see it from the surface when you're using a regular white light bronchoscopy. So with this mode, you will be able to see a lesion which is a blood vessel which is deep inside the lesion, so that you can avoid that particular area for biopsying and you can avoid bleeding. That is the advantage of RDI actually. So and the eye scan, I didn't have an opportunity to use that, but it's basically for again looking at the superficial vascularity pattern. I'm not sure what is its utility. So there have not been any head-to-head randomized control trials of these on these newer modes actually, TXI and RDI or eye scan. I should say that these are technologies in search of indications actually. We have introduced the technologies, but now we need to search for indications for this actually. Probably
So
in countries like Japan or somewhere where the mucosal lesions are very significant and they want to find out these dysplastic lesions, take a biopsy and then do some kind of therapies, photodynamic therapies or some of these therapies for early mucosal lesions, just like what they do for other cancers actually. This might be helpful actually. But in Indian setup, I think I'm not sure whether they'll be useful or not. Probably I can tell one use case where there was a smoker who had come with minor hemoptysis. There was a plaque-like lesion used an NBA. There was an altered vascularity. Then we took a biopsy. Turned out to be dysplasia. The doctor who was the patient himself actually said that I want this to be ablated. Then this dysplastic lesion actually on biopsy we ablated using a cryo. And then I think 1 year later we repeated a bronchoscopy and saw that the lesion has healed. Actually, there is no visible superficial mucosal lesion. So this is a single use case which I can say, but in the clinical utility in regular practice, I'm not sure how they will be useful. All these things.
Dr. Vishwanathan very nicely said two things. These are technologies in search of indications. Such beautifully said. So I think no one should. I think I'm not against any of the companies who are bringing up these modes, but we should not buy a scope for using these modes. RDI, TXI, iScan, BLBLI, NBI, LCI, so many are there. So many are there. But none of these have been shown to increase the diagnostic yield. RDA has one unique advantage that it will identify bleeders. If you in a bloodshed area, it will tell where the bleeding is coming from. Deeper vessels are better seen. That is one unique feature of RDA is what I would say. And second, before we move on to the innumerable number of questions which are pouring in, I'm sorry I may not be able to take all of them, but in the next 10-15 minutes, we'll cover some of them. I would request Dr. Vishwadana to also send his case of use of new modes for dysplastic identification ablation for publication in the Annals of Intervention Pulmonology as a case report. I think that is,
Definitely. Thank you.
and
Thank you.
for all of you who are listening, so IAB has also started its our own journal, that is the Annals of Intervention Pulmonology, which is a journal dedicated for intervention pulmonology. So as we are seeing, listening to all the experts here, and I'm sure a lot of us are there who do amazingly great work, but we don't end up publishing. So I think this is an opportunity for all of you to send your articles, original articles for publication to the Annals of IP. Now, there are lots and lots of questions, but I will take up some of them which I feel are very, very important. So one, I think there are more questions about navigational bronchoscopy than the newer scopes, but I think that is probably the interest. So what is the personal cutoff below which you hesitate to attempt a bronchoscopic biopsy? Is there a cutoff like that, Dr. Sham? This
I
is by
feel
Dr. Sachin from
anything.
Mumbai.
So I feel anything less than, I would say 1.5 mm of lesions which are very close to the diaphragm, which both me and the radiologists are scratching their heads like who would do first, you know.
So
So
what
those are
is
the
more
lesions.
important? Is it the size or the CT bronchus sign?
CT bronchus sign, I feel, is definitely
Yes, I think
very important.
very, very true. Even if there's a small lesion, if you're seeing a bronchus going into it, your confidence suddenly jumps up. But
Exactly.
definitely, as what Dr. Sham has said, anything below 1.5, you'll have to think twice and then be very, very sure before you go in. I think other thing is the location. Very lightly said. The more apical it is or the more basal it is, it's a problem. It's a problem. So I think that is very nicely said by Dr. Sham. But then there are other questions. Uh, what percentage of your peripheral lung lesions are now approached bronchoscopically, Dr. Nitish? This is
So,
from Dr. Kunal from Pune.
yes, sir. So after the introduction of navigation bronchoscopy as a setup, so we first of all try ourselves to reach the lesion. In case we fail or it turns out to be non-diagnostic, then we call up the radiologist.
So
But it is the
100%
now,
bronchoscopy first.
yes, sir. So it's now the
For
first
Dr.
us
Nitish.
approach.
I'm so happy. Dr. Vishwanath from AIG, what percentage would you do? What percentage would you send to CT carrier biopsy?
It depends upon the location only. Suppose we feel
No,
that
no,
there is
only percentage, only percentage.
yeah, percentage is like you can say 60-40, 60% of them by bronchoscopy, 30 to 40%
Bronchoscopy,
by
40%. Dr. Anshu madam, at your center. Bronchoscopy percentage, CT carrier biopsy percentage.
So we are a tertiary cancer referral center. So most of my nodules then come up on follow-up. It is very unlikely that a patient has come without a biopsy to our center because the file would not be made. But when we do have on follow-up, I think we look at, I would say it would be around 50-50 depending upon the location of the lesion.
50-50. That's all I want. Dr. Hari.
Probably around 80% bronchoscopic and remaining 20% would go for
So
CT.
Hari and we are very close by 80-20. I think that is where we are. Dr. Nitesh is the highest 100-0. That is also see, basically the I think that is the message which should go as a pulmonologist. We should advocate for a procedure which is more safer than a CT biopsy and which has a comparable diagnostic accuracy. That is the take home message. Yes. So now have you experienced very beautiful question? False reassurance after a negative navigation biopsy. Dr. Gaurav, he has not written from which place it is. I think this question has to go to Dr. Shah.
So I just want to. So what is the question? Have you experienced?
False reassurance after a navigation biopsy.
So I mean, see, my pathologist is so he gives me the reassurance every time. So especially after Rose, he says, I see a typical or atypical cell, you know.
But the problem is if it is negative,
Yes. So and
are you
it's
how?
turned out. It's turned out to be negative. And
Hmm.
then you have nothing to say, but then you follow up the patient, repeat a scan after some time, tell him that, you know, you're still, and the patient is very happy that time, you know. You say the initial suspicion is there, but then the results comes negative, and he says, "Doc साहब देखो, एक तो कुछ भी नहीं है, you know." So finally, so there's no cancer, you know, and you have to agree with him. See, then you have to tell him that no, it's not that way, but we still have to keep a watchful eye. Or I would recommend a follow-up CT and see if the lesion is increasing. Then I would go for a rebiopsy, or I would take a
Very
second opinion. The
yeah.
same
I
sample.
think this is a very important thing that as per the definitions of a diagnostic yield, only some of them have been considered as a definitive yield. That is, if you get a malignancy, yes. If you get a definite granuloma, probably yes. But otherwise, most of them, we should be very wary. If you get some non-specific inflammation, if you get organizing pneumonia pattern, so we should not leave it there. Correct. That is a very important thing that you should follow the patient till it resolves. Only then you can be very, very confident that what you have got as negative is true negative. In fact, in our center also, whenever we get OP, we have followed up the patient, and then some of them are actually not isolated OP. That's paramalignantopy and so on and so forth. Very important that if you don't get a definitive diagnosis on pathology, which is either granuloma or malignancy, the two definitive things, you should be little wary and you should not be falsely reassuring yourself and your patient. And that is the thing. Then learning curve. This is again very important. By Dr. Nandini from Kerala. For navigational bronchoscopy, did your yield improve after a certain case number? Dr. Nitesh, I think after using Synapse, do you need a learning curve for Synapse?
So learning curve is in memorizing and tracking the pathway with the synapse because it does not give the live pathway. In order
Mm.
to remember, you have to find a technique. You either keep the both the screens together or you ask somebody to dictate left, right, up, down, and
Correct.
that takes time. It takes time. Maybe after 3 4 cases, we were more able to communicate it easily, and that shortens the actual. The purpose is to shorten the procedure time and increase the yield. So shortening of time happens after 4 to 5 procedures.
Yes, I think very nicely said for manual mapping and navigation. Dr. Sham or Dr. Hari?
Yeah.
So,
No, I'll just go
number of
back to the
cases.
learning curve part.
Yes,
I'll
please.
just go back. So, so now with the latest robotics coming in, they say that the learning curve to teach a robotic bronchoscopy to a bronchoscopist probably takes just 5 to 6 procedures, it seems. And whereas teaching him a cone beam CT or a radial EBUS takes at least 25 to 30 procedures. So now what they're telling is forget the radiologist, forget the pulmonologist, teach the surgeon the robotic bronchoscopy. He will diagnose it and he'll remove the nodule in the same sitting. So
Mm.
I guess this thought process also we should be wary of is what
I think this brings me, I will just sum it up that each technology has a different learning curve. Hmm. The simplest is the VBN, where no learning curve is needed, only the memorizing the path, followed by robotic bronchoscopy, as Dr. Sham has said. Again, it's all there is to play it. But technologies like cone beam CT, CM based tomosynthesis would have a slightly longer learning times. In fact, we have published our experience also. Our diagnostic yield with CBCT improved after 25 cases. First 25, we were around 80-ish, then we went to 90%. So probably 25 is the number. I think that would be true for CABT also. That is mainly because of the number of steps involved. In CABT, CBCT, more steps are there, so it will take some time. Whereas if you go for more complicated things like tunneling, I think it's even more steeper learning curve. It will take even more time to learn the procedure. So the learning curve is different for different procedures. That is very nicely brought out by Dr. Sham. Then three or four questions are about not the navigation per se, but about again, I think very important to cover about this thing is what is the optimal sampling tool which we use. Needle, forceps, brush, cryo. Hmm. So this is by Dr. Daya from Vijayawada. I will ask two panelists, one Dr. Vishwanath and two Dr. Anshu Madam.
So, nowadays, after the mini pro cryo has come, for all cases, first we try to take mini pro cryo biopsy as the first option because if you take a forceps, we get a tiny tissue. It creates some blood in the field. Then you'll be busy trying to suction it, clear the vision and everything. So the first biopsy and the first piece which we take during the cryo, like radial biopsies, is the best one actually. So if you have to take the best biopsy, the best tool for taking biopsy is mini pro cryo. In centers where cryo is available, I think 1.1 cryo probe should be the first option to take biopsies. I want to.
Will everybody agree with that? Cryo as the first modality, the expert panel.
So we go ahead with forceps biopsy, especially if we are seeing an end-on lesion or a bronchus leading straight to it, and we prefer cryos more for eccentric lesions just because of cost issues and uh, for those reasons. So we find that if there is an end-on lesion, even with multiple forceps biopsies, at least we do manage to get good tissue and diagnosis. I think it's also because we also have very good pathologists at our center, so maybe that would also probably play to it as such.
So a point to remember is that this 1.1 cryo is a single-use cryo, bro. So ideally, it has to be discarded after one use. I think in India, nobody actually does the thing. But so if you use it in the single-use sense, the cost is going to be much higher. So Dr. Anshu has given a very scientific answer that head-on lesion, concentric lesion, forceps should suffice, eccentric lesion, cryo. But Dr. Vishwanath's practice is what is our practice also. We do cryo in all cases because after we see the size of cryo, we are not satisfied with the forceps sizes. But then every center can have their protocol. We cannot say that one modality is always better than modality. It's always important for the center to have all the all the sampling tools ready in hand so that they use it ideally and correctly whenever it needs to be used. I think there are so many more questions. I'm really sorry to all the delegates that we won't be able to take all the questions. So before we wind up the session, we're already 26 minutes late, and it's also very gratifying and satisfying to note that 2,300 people are still online. I think the panelists have done a great job. And before we wind up the session for today, I would request each of the panelists to say one take home message for the audience here about navigational bronchoscopy and newer bronchoscopes. We will start with Dr. Nitesh, who is the speaker.
So the one take home message is basics are always there to be kept forever. And learning and adapting new technology is essential for because they are safer for the patient and they reduce the procedure time as well as increase your diagnostic yield. So whenever
Yes.
a technology is there, we must learn about it and we must not straight away reject that it is very costly and we cannot afford. So we should not know also about it.
Yes. Dr. Sham.
So I feel like, adding on to what Nitesh said, early adopters always, I feel is the right approach, especially youngsters. Uh, Always start with a larger lesion first. Don't start with small lesions. Start with a larger lesion where you can even do it under a plain fluoroscopy guided TBLB. But just to understand the learning curve and the nuances associated with a particular technology, start with a larger lesion and then proceed to smaller lesions.
Dr. Anshu, madam.
Yeah, just to add on to that, I would agree with that you should start with more accessible, larger lesions. As you get more positive results, your confidence also builds up, and then you should progress to more high risk cases or smaller lesions. It's not just about the person doing the procedure. In a lot of these setups, especially when you are using cone beam CT or C-arm based technologies, it is also the coordination in the room, so your team also has to be geared up. So it's not just the learning curve for the person doing the procedure, but I would say it's also the learning curve for the whole team, which is helping you doing the navigation procedure.
Yes, Dr. Vishwanath Anna, on newer bronchoscopes.
Okay, I actually wanted to talk about a different thing. So I would strongly suggest and recommend all the youngsters to learn manual bronchial branch tracing, which will be helpful in any setup, whether you have a technology, whether you don't have a technology, and it will be helpful not only in malignancies, infections as well, actually. And it's the cheapest technology. It has a learning curve. It comes with maybe like any other technology. We have a learning curve. Probably after 15 to 20 cases, you will be able to trace the bronchus path very well, even with manual mapping, with just a CT with you.
Dr. Hari, on newer bronchoscopes. Dr. Hari, you're in mute. You're in mute.
So newer bronchoscopes, I can't think of a new indication per se. I think it should be judiciously used. Its indication shouldn't be forgotten that, you're going to use it for a single use, although many of us use it again and again. But the actual use is a single use one. So the disinfection, sterilization, everything needs to be very well taken care of.
Yeah. So thank you so much, all the esteemed panelists, for this amazing discussion on navigational bronchoscopy and the newer bronchoscopes. I am sure that this discussion can go on for days together. Such is the magnitude of the topic, the interest in the topic. I think this is a very practical thing for all of us. But before I end the session, I would like to say that though these technologies are there, it is not essential that everybody has to invest in these technologies. I think for the vast majority of pulmonologists who are practicing bronchoscopy, 90% of the work for peripheral lesions can safely be done, easily be done with adult or a thin scope and with manual mapping and with basic technologies also. But at the same time, India being a very diverse country, we should have centers of excellence. So we should have centers of excellence where all of these technologies are there, all of these technologies are being practiced, and that there should be the referral point for tougher lesions, smaller lesions, and that is how India should evolve altogether. We would not want to give a message that everybody should have a navigational bronchoscopy, everybody should have manual navigation, and the so-called centers of excellence should have each and every technology which is there so that all the patients can equally be benefited. So with this, I would once again thank Indian Association of Bronchology. I would like to thank Mankind. I'd like to thank Olympus. I'd like to thank the speaker, Dr. Nitesh, all the panelists for their excellent comments, insights, and thoughts, and also all the audience who have been with us from before we logged in and till now. So thank you, everybody. I think we will call it a day and we will wind the webinar.
So Nagarjuna, thank you. You've moderated the session so well,
Thank
and
you so
you've
much.
given out the right take-home messages. And I'm sure the audience would have, definitely benefited from your moderation more than our. Uh,
Absolutely second it.
channel.
Thank
Yeah.
you so much. Thank
Right.
you so much. Yes, sure.
Thank you.
Okay.
Thank you, sir.
Thank you,
Thank
Hari
you.
and
Okay.
Dr.
Thank
Anshu. Bye-bye.
Thank you.
Bye,
thank you.
bye, Dr. Nitesh.
Thank you,
Bye.
sir. Thank you.
Bye.